While on a medical outreach mission in a low-income country, you encounter a patient who insists on pursuing a herbal therapy for menopause, which conflicts with the evidence-based guidelines. How do you handle this ethical dilemma?
So in context to this question, I think it's really important to consider the cultural, societal, and religious differences that we may have due to being from a high-income country versus a low-income country. So I would want to ask them why they feel this way, what information they have, and really explore that and get down to the specific reasons why. And I think then once you've identified and pinpointed what the area of difference is, it would be the best idea to explain your evidence behind why you disagree. But I also think with this question, it's a little interesting to know when they say conflicting opinion, does that mean that they are completely against the treatment that we would be suggesting based off our evidence? Or could it be that they really, really want to continue with their approach to treatment, but they would also be willing to offer and continue with our treatment? And I think this might be a really positive way to go forward, to say, okay, brilliant, you do what you have your knowledge of, and we respect that. It's patient's autonomy. They can make their own decision about their own healthcare, but to try and help educate and help them understand why our certain treatment might be beneficial on top of that. However, I think we need to consider medicinal interactions here. If we're not quite sure what the medications that they're taking, if they're herbal remedies, and whether they would have the interactions. For example, I think, is it St. John's wort is quite a commonly used herbal medication, which actually has some quite detrimental interactions with certain drugs. So things like that, we would really want to clarify and assess before moving forwards with the plan. And I think if it was actually that they were completely against our idea, even after we've had a discussion, we've pinpointed the points of difference and maybe shown them why we feel that this other option is going to be better for their symptoms, because we want to treat them and we want to help them as much as we can, but they still think that having assessed all of that information, that they want to continue with their idea of treatment, then we have to respect that. Patient has the choice over their own medical treatment, and all we can do is try and help assess and give support to these patients. They can come to their own conclusions, and we are not here to judge, we are just here to support. And even if further down the line they want to come and try the treatment that we are offering, I think that's a really positive way to deal with this.
During a clinical rotation as a medical student, you witnessed a healthcare professional stealing painkillers from the ward. How would you approach this situation?
I would want to assess the situation in terms of the actual act of stealing initially. I'd want to understand where they'd taken the drugs from. Has it been noted down? Maybe did they record it as though it was a prescription for someone, but actually take the drugs themselves? Did they put it in a bag that they were going to take home, or was it something that they were taking on shift, for example? Because I think we really need to assess, first of all, the facts of the situation, but also the impact on the clinician themselves and the patients. If we think about the clinician, first of all, if they are taking a medication which hasn't been prescribed to them, the negative effects that could have. Is this going to impact how they're able to work, which is potentially putting patient safety at risk? Is it that they are taking them home and maybe going on to sell them because they're suffering from financial hardship? Or maybe they're taking them home because they have a certain prescription addiction, which can be really difficult. So we really want to understand that this could be a very difficult time for the person that is stealing, but also we cannot underestimate the effect that this can have on the patients. It's taking drugs away from patients who need it. Drugs are in limited supply. We see in the news all the time and from reading that there are certain drugs at the moment that are really struggling with production and they're having to be limited. I think I've read somewhere that some of the new diabetes drugs that are given via injections normally, all of the brands are struggling to produce them, and this is meaning people cannot be even initiated with the prescription. So things like this we really need to understand. And also, again, going back to, is this going to have an impact on the clinician themselves? Are they fit and healthy, ready to work and keep patients healthy? So first of all, I'd want to assess, like I just said, and really understand how it could impact the people. And then I think the important thing to do is to report it to the relevant people. So individual NHS trusts, individual hospitals and wards have different policies, procedures, whether from whistleblowing or from reporting it to managers. So I would follow whichever protocol is in place on my ward, and ensure that there is education from the situation, that we're ensuring that all drugs are being checked, ensure that drug safety in terms of what's coming in and what's coming out is being correctly monitored as it should, and also offer support for all of the team. Perhaps the person that has been stealing does need that extra welfare support from appropriate services, and to make sure that all of that is happening. So I think, to conclude, it's a really difficult situation, but we need to remember that it's putting patients at risk. So we would want to identify, assess the impacts and report straight away, and then offer any support that we need to the relevant people.
As a medical student, how do you approach a patient who refuses to engage in understanding their diabetes diagnosis and medication?
I would want to assess the individual patient's diabetes diagnosis. I think there are some cases that are less severe, and I think in these cases we would offer the alternatives of really trying to improve the lifestyle factors instead. We appreciate that in busy people's lives, the medications can be hard to stay on top of, especially if they're having to take them at strict times of the day and around certain meal times, and maybe help educate them and support them with cutting down on the high risk foods and smoking and living a generally heavy lifestyle instead. So I think in that case, if it's a mild form of diabetes where we can have more preventative measures put in place, that's what I would do. So I would acknowledge that it's going to be difficult and probably a different approach is better. But I think if it was for someone that had severe diabetes, then I really think we would need to offer a lot of support. Like I just said, taking lots of medication throughout the day and taking insulin, which typically I think is given via an injection. These are really can be quite overwhelming things to deal with when, people still want to continue living their lives. It can be very overwhelming. And to acknowledge that to the patient, be like, look, I can really understand why you may be having difficulties with this and why you may not be wanting to or easily be able to take the medication. So I'd offer them that empathy, but also say how important it is that they do take the medication, because without it, their condition is only going to worsen, and we really want to prevent that. So I would want to assess if it is more of an education point of view, that maybe they're not quite sure how to inject the insulin or when exactly they need to be taking the medications, and whether they just need some help, support, and just extra time to talk through these things with them. Or if it's maybe an access reason, maybe they're struggling with their mobility at the moment, maybe they're struggling with their dexterity in their hands. I think when you're injecting something, that requires a lot of manual dexterity. And so exploring whether care plans need to be put in place. Do they need support with taking the medications in the form of someone coming to visit, such as diabetes nurses coming to visit them in their home to help them with their medication, if it's not a kind of awareness thing? So I think this is a really interesting question. It really depends on the individual patient, and the important thing is to really understand why in their case that things are happening the way they are, and then help support them accordingly.
As a medical student, you notice a senior doctor prescribe the wrong medication to a patient that could cause serious harm. What would your response be?
As a medical student, I think I personally would be quite inquisitive in this situation. I think I would try to be non-confrontational and go in with an open question with something like, oh, can I just ask why you chose this medication? Because I think from a medical student's point of view, you don't understand, you don't know all of the drugs, you don't maybe specifically know that patient's condition. And in some cases, maybe with drug allergies, they have to give an unexpected medication. Maybe in this specific case, whilst a drug is probably given to the majority of the population, there might be a specific example of why this patient needs that different medication, which may seem wrong to you. So I would ask that question of, oh, can I just ask why you use that? And say if they gave you an answer and you still weren't quite sure, I'd maybe say, oh, because I read that sometimes this other medication is given. And then if it gets down to the bottom of it, that actually it has just been the complete wrong medication, then I think that's when we can respond. So first of all, it would be ensuring that it is reported to the correct people alongside the hospital trust's recommended procedure, that you as a medical student should know who to report things to, who is there for protection. So I think report. And I think education is the main thing. So once it's been reported, we need to ensure that this doesn't happen again, and that we have helped educate people on, say, new guidelines if a new drug has come into place, or why that specific drug has been given, and just make sure everyone does a little bit of a refresher to make sure that none of that happens again. But also, and I think on a more ethical side of things, I think it's really important to ensure, duty of the doctor is to be honest, it's to be open and honest, even when mistakes have happened. And I think it's ensuring that the patient and their family are aware of the mistake that happened, and also then explain to them what has been put in place to make sure that that doesn't happen again, and offer them the support and kind of what we're going to do to try and fix any problems that may have been caused. So a management program for any impacts they might have, but also the emotional support of you've placed your trust in a doctor who has made a mistake, and it's about building up that relationship again so that they are still trusting and know that how we've tried to change that. So I think in conclusion, as a medical student, I would be inquisitive, open-minded, and try to get down to the bottom of things, but then report and educate and offer the support that is relevant.
You are a junior doctor in general surgery. Your consultant is removing a kidney tumour and notices a tumour also in the lung. The patient has only consented for the kidney removal. What would be your next steps?
So consent is the most important thing, and it's really great that we've got the consent to remove the kidney tumour to help the patient. But I think it's important to acknowledge that we do not have any consent for any other treatment. So in this case, I would straight away recommend that we do not touch the tumour that we think we can see in the lung. And I would say continue with the surgery as it is, to finish the surgery and to then work from there. Because I think there's so many different avenues that this could go down. For example, us as surgeons looking into the body, we cannot correctly identify whether this is benign or whether it's malignant. It could just be that it is a fatty deposit and it does not need to be removed. We also don't necessarily know that it's cancer or what type of cancer it is and what's the best form of treatment, because I think in some cases with lung cancers, they actually treat people with chemotherapy first before they go in for surgery, and that would therefore not help the patient's journey. So I think the most important thing is to recognise that we would not be able to have consent from the patient. Consent is the most important thing. We would need for them to be awake and for them to have informed consent to understand all the risks of the procedures and the impacts that would happen if we were to remove the lung tumour. But also we would really want to have the best approach with a multidisciplinary team that really is trying to target and have the best treatment for the patient, rather than just removing it without any knowledge. For example, I think the key thing is whenever people have cancer treatment, I think they need a biopsy first to really characterize the tumor. For example, to know what grade or what staging it is, or exactly what kind of medication is best appropriate, or if surgical treatment is the best. So as a surgeon, I think we should in this case step back, tell the patient what we have found and how we are going to go about investigating the root cause so that we can have the best treatment possible for the patient.
It is completely unacceptable for new medications in clinical trials to cause harm to patients. How far do you agree with this statement?
So I understand clinical trials to be incredibly well-developed things, particularly before they even reach the patients. From what I know, they have to have completed experiments on cells, on animals, to really assess the toxicity. So is it causing harm to the cells and to the animals? As well as the efficacy of how much do we need to give to see our desired effect. So I think before we reach the patients, we have done as much as we can to try and eliminate as much harm as possible. I think that's the first thing to consider. But also the importance of clinical trials. So clinical trials are put in place so that we can try and improve patient outcomes, reduce the morbidity, reduce the mortality, and they are a new drug that hasn't been tested. So they start off in healthy humans and then go to the patients to see, is it actually going to have an effect on the patients? So we really can compare and have the statistics available to us to compare it to the gold standard that is currently given, for example, in the NHS, what's given in the NHS guidelines of what to do, to see if we can really help and improve. So I think they are really important things that need to occur in order to further progress our healthcare. But it's also important to not underestimate the harms that can occur as a result. Now, historically, there have been cases where clinical trials have had very significant harm to patients. But we've learnt from those mistakes and we put protocols in place and we put regulations in place to really help prevent that. For example, by having our animal testing, by having our cell testing and things like that. So now we understand that there may be harm, but these typically, as far as I'm aware, come in the form of side effects. So side effects happen with a variety of drugs. With majority of drugs that are prescribed on the NHS, there are side effects and these can be harmful. However, in most cases, the risks of the side effects and the harm that is caused is completely outweighed by the benefits of the drug, of how much of an impact it has on the patient and their health. So yes, they do cause harm, but we need to contextualize the harm in response to the benefit that it is giving to the patient. And I also think it's really important with the recording process and the learning that we get from clinical trials. Say if the drug was to be approved and to go be ready to be prescribed in our NHS hospitals, we really want to know every single side effect or harm that it has caused on the clinical trials. You know, if we think when we see a patient leaflet, there's always the big long list of the potential side effects and the incidence rate. So how common are they? Is this something that is going to commonly affect everyone? Or is there sometimes some more rare, more serious side effects? So I think it's about making sure that we are aware of all the possibilities if these drugs were to go to the market and are deemed as having that much more of a benefit on the patients, so that we can have processes in place of how to treat maybe some of the side effects, whether there are some alternative that we can give or medications that we can give to try and combat the side effects. So whilst I appreciate that it is never nice when we get side effects or when harm is being done, but I do think it is acceptable in this case of a clinical trial, because the aim is we have ruled out all of the really serious side effects and the harm with our regulations before it comes to the patients, and our aim is to really improve from our already gold standard treatment that's given in the NHS into something even better, which is impacting the patient's morbidity and mortality for the better. So I disagree with the statement to conclude.
You are a junior doctor caring for a terminally ill cancer patient who is in constant back pain. The patient's family believes he needs a higher dose of painkillers despite currently being on the safest dose. What would you do in this situation?
We need to acknowledge, first of all, that this is an incredibly difficult time for both the patient and their family. And we want to give them as much emotional support and medical support as much as we can. So I think the most important thing is to be really collaborative and involve them, have it a patient-centered decision making, but ensuring that we have everyone collaborating together to get the best outcome that we think is appropriate for the individual patient. First of all, I would want to get down to the bottom of what is causing the pain. So in this case, we know that they are a terminally ill patient, and I would want to investigate, has their condition worsened? For example, with this cancer patient, has the cancer spread to somewhere else that we aren't aware of and that we need to investigate and maybe change medications or treatments as a result, and that is what's causing the pain? Is it something medical that we need to look at? I also think we should assess if it's maybe a positioning or a rather than pathological reason for it being them being sat in bed in a specific way. Do they need support of a physiotherapist or an occupational therapist if they're at home and they need different access or different support with mobility or things like that? So I think we want to get down to the bottom of what is causing the pain, and then offer the variety of options. I think it's really important in this case to involve the palliative care team. As you said, this is a terminally ill patient, so having the whole multidisciplinary team, the physiotherapists, the occupational therapists, all of the cancer nurses, having the palliative team involved, as well as the person that is in charge of looking after them, and explore all of the different options that is going to have the best impact on the patient. This doesn't necessarily involve increasing the dose of medication. This could be maybe offering an alternative type of painkiller. Maybe this one painkiller isn't suitable for the patient anymore if they need to be transitioned onto another, and work with the palliative team to see what their care plan says. Or, like we said, maybe it's adjusting the bed heights, or with the support of the occupational therapist of kind of assistance with movement, and that's what's causing the back pain. And making sure that the family are really informed and really help work together as a team of what do you need from us and how can we best support you as a family while looking after the patient themselves. So I think overall in this situation, it's an incredibly emotional time, and we need to offer our medical support, but also our emotional support so that we can work with the multidisciplinary team, the family, and the patient with what they want to do to help relieve their pain and have a pain-free end to their life.
Alcoholics do not deserve to be treated for alcohol poisoning. Explain whether you agree or disagree with this statement.
So the NHS is free at the point of care, and it is a non-judgmental service whereby we only treat based off clinical needs. So in this case, I disagree with this statement. It would go against our duties as a doctor and our ethical standards. For example, the non-maleficence. By not treating someone who is experiencing alcohol poisoning, this could lead to further health issues. This could lead to brain damage and could lead them to require even more hospital support. And we always want to act with beneficence. We always want to do the best for the patient. And in this case, a patient has come in, and whilst they may have alcohol misuse disorder, that does not mean that we should not treat them. We should treat them with care and with our best clinical capabilities. And actually, if anything, I would say that this person in this case would need the extra emotional support and extra medical support in a very collaborative way. I think that need to collaborate with their local GP with a whole team to help put in place referrals, whether that be Alcoholics Anonymous to offer them support, whether that is support groups outside of Alcoholics Anonymous, whether they need counselling, whether they need any extra support in that way to really help prevent these cases from happening. Just because someone has alcohol misuse disorder does not mean that they don't deserve to be treated. They deserve the respect from everyone and to help guide them with the help that they so require. So I disagree with this statement, and I do believe that we should treat anybody and everybody that walks through the door in the NHS, because we do not discriminate and we decide who we treat based on clinical needs.
Charlie Gard was diagnosed with a genetic condition that has no known treatment and leads to death in infancy. Unfortunately, Charlie's condition deteriorated and the doctors recommended withdrawal of life support and said that further treatment would be futile. Charlie's parents challenged this and wanted Charlie to receive experimental treatment in New York. Was it right for doctors to withdraw life support?
So I think first of all we need to acknowledge how much of a difficult and emotional situation this is. Any parent always wants to try and do the best for their child and to really help prolong their life. However, the doctors had to intervene in this case, and I think from a doctor's point of view, they always want to alleviate suffering. In this case, with Charlie's worsening condition, there was palliative care that needed to be put in place. They deemed it as being unrecoverable. And by going to New York, by flying overseas, by people that don't necessarily know his condition as well, could potentially only put more suffering onto Charlie, and that is never the aim. And also the fact that it's an experimental treatment, that there is not a strong evidence base behind it at that given time, means that the suffering may continue. There may be side effects as a result of this treatment. There may be complications. And this is something incredibly difficult to deal with, especially in this case where Charlie has such a complex genetic disorder, which requires a lot of care. So whilst the doctors really appreciated how difficult this situation would be, I think in their eyes, they just wanted to alleviate the suffering for Charlie. But also we can really feel for the parents and see where they're coming from. Whilst it is an experimental treatment, sometimes experimental treatments do work and they go on to become the regular treatments that are given. So for them, there is a difference between withdrawing someone off life support where that is then definitely the end of their life, or taking that risk of potentially the experimental treatment working in this case. And so the kind of hope from that situation, you can really understand why the parents felt this way. But I think ultimately it was right that the doctors made that decision, because they understood the suffering and the consequences and just the logistics of having to complete this treatment in New York, and they expected that Charlie may not even survive to continue to go on to New York, and they really wanted to make sure that he was comfortable, that he was pain-free, and that he had the people around him to support him. So whilst we can completely understand why Charlie's parents didn't want this to happen, that it was in the best interest for Charlie.
Preimplantation genetic testing allows for the screening of embryos for genetic abnormalities before implantation during in vitro fertilization, also known as IVF. What are the potential benefits and pitfalls associated with the preimplantation genetic testing?
So if we start with the positives in terms of beneficence and non-maleficence, by knowing if there are going to be any genetic conditions, we can help put plans in place to help deal appropriately with these conditions, whether that be, could we have medications that are ready and waiting at birth? Maybe if the newborn needs to go straight in for surgery, we can have all of these plans put in place to really help reduce as many of the effects as we can. So by educating that and having everything in place, we can help increase our health. However, with that also comes the idea of the slippery slope of, if we do know about genetic conditions and genetic abnormalities, is that just a genetic condition and a genetic abnormality? Is it something which could be more a bit of a blurry line of, is it considered a genetic condition? Or is it just an impairment that a child may live with? For example, maybe they have a hearing impairment. Is that viewed as a genetic condition that we need to know about before or not? And then down the slippery slope of potentially it becoming further down the line, characteristics that we can pick out and that we can eliminate and therefore not continue with in pregnancy. And this is a very dangerous situation. Life is life, and it's really important that we respect life, and that this idea of designer babies is not what we want to get down to. So I think whilst it's really important that we can conduct genetic testing to really help prepare healthcare plans put in place, we also need to acknowledge these potential negatives. But I think a way to kind of eliminate some of the negatives and help alleviate some of the stresses that it could put on the parents, because we can appreciate this can be incredibly emotional and quite a tough decision, is genetic counselling and support that's really available for parents that are going through IVF, where they can receive unbiased opinions, where they can really help be educated and receive the support that they need whilst going through this tough time to help guide them in their decision making. But also the role of healthcare authorities of making sure that we have regulations put in place to really help stop going down the slippery slope of picking out characteristics that can result in designer babies. So overall, whilst there are undoubtedly some positives from testing genetic conditions for IVF, we do need to recognise the pitfalls of the potential slippery slope and try and prevent them by putting strong regulations in place. If you enjoyed this video, you'll love our online interview course, so feel free to check it out.